Welcome back. The first technique that we're going to have Brian demonstrate will be SNAGs for the lumbar spine. Brian, this patient comes into your office and they have pain and or loss of motion. We've screened the patient. They have no contraindications for manual therapy.
Good.
And SNAGs are appropriate for this patient.
As a trial.
As a trial. On day one, we will limit our number of SNAGs to 3 repetitions. When they have pain, we will reserve this technique for patients who have pain above the knee, into the buttocks, maybe into the posterior thigh, but certainly no reference of pain below the knee.
So we're talking about a patient, when they bend forwards, they've got pain either in the back or the buttock, but
Correct.
not below the knee. That's
Correct.
important.
Correct. So this patient comes in with their complaints. They complain that they have pain in sitting more than standing. Where would you start your care?
If a patient, some patients only have problems when they're standing, bend forward to touch their toes, and they can't get down and they've got pain. I would also assess them in sitting. And if they have a problem in sitting as well as standing, I start with them sitting. Let's start on a position that's better for the patient, and I'm not wanting to upset a patient. So if they have problems in sitting and standing, start in sitting. It's more gentle, less stress on the spine than when they're standing. So
you would then progress the technique to a standing technique?
Yep. Okay. I would progress to standing.
Let's take a look at your technique.
All right. A self-snag for flexion. The patient, when sitting up straight for a moment, starts to flex, and just drop your head first and just see if you can roll your spine. And the pain comes in. They say, yes, it's hurt. It's painful. And the painful side may be the side that's closest to me on the right. They come up again, and that's okay. Every time they go forward, they've got pain, and they're reluctant to go any further. Let's assume that as a result of your assessment, they've got an L3-4 problem. The pain comes in when that segment starts to flex. So what are you going to do? You're trying to separate the facets. The first thing you do, when you're lifting a spine and working on it, there's a tendency for the patient to feel insecure that they're going to fall off the bed. So we'll always use a belt, and we locate the belt just below the anterior superior iliac spines. And that is not a belt that you're going to pull back strongly on. You just keep an even pressure. Can you just feel that pressure? But it's not horrid. If you put it where the abdomen is and put any pressure on the tummy, you might see what they had for breakfast. So please make sure this is below the anterior superior iliac spines. Now I'm going to give a lift in a cranial direction using the hypothenar eminence just distal to my pisiform.
So Brian, also when you talk about the belt as a brief bit of security,
yes,
you also make sure that the patient's feet are on the floor and that they're in a stable position as well.
Yes.
So this table is a little bit wide, but we certainly would have a stool or a chair under the patient's feet.
And that gives them added security.
Just to give them some added security.
Yep. So we're working with a small handicap here, but we're able to cope with that. Now, to get some lift on the spine, I put my other hand on the bed as a counter pressure. I'm pushing down with one hand. My right hand is pushing down on the surface of the bed, while my left hand is going in a cranial direction. Now, I'm going to locate on the appropriate spinal segment. And as I've said, I'm using that hypothenar eminence. There's the lift. And once I apply a lift, I ask him to slowly go forward. Slowly go forward, and he keeps going. And that's marvellous. I sustain that as he comes up. Up you come, and have a rest for a moment. Let's talk about it. I made an attempt to separate those surfaces. If that attempt was satisfactory, in other words, it was more than an attempt, I did the right thing, he will now go forward with no pain at all. And if I would have communicated with him before we started to say, if you feel any discomfort, stop. And of course, he knew that, and he would have told me. But there we are, that's a central technique. Now, sometimes he's fine, but sometimes people are too slippery. And sometimes those spinous processes are uncomfortable just to touch. So we can use a piece of foam beneath our hands.
And again, with the central technique, you're making contact on the superior segment of the vertebral segments that you want to separate.
Yes, if you've got 3-4, you must be on
Lift
3.
3.
If you're on 4, you'll jam it. and they'll be worse. And quite often, you are on the wrong segment. Your judgment's wrong. And they say, oh, just go up to the next segment and try. And they'll say, yes, no pain. Okay. Goody. Now, that's a central technique, and it really affects the facets equally on both sides. Most people have unilateral pain, so we treat them on the side of involvement. So that if it's a 3-4, there's the spinous process of 3, I come up about an inch and I locate laterally on the transverse process. Hand on the bed, there's the lift, and forward he goes. And I'm just come back again. And Dave, could you go and get me a little bit of sponge out of that bag? Okay, we've decided it's an L3-4, and we're going to do flexion and sitting. So I'm going to locate my hypothenar eminence on the spinous process of L3. My other hand goes on the bed as a counter pressure, and I'm going to give a lift. Now, while I sustain that lift, I'm going to ask the patient to bend forward slowly, because if they bend too quickly, I mightn't go quickly with them. So that's raising an issue we didn't mention. And then back again. Goody. Now, that's a central technique, and you can do it with plastic foam when things are tender. So we're going to put a bit of foam, and I'm going to ask our friend here if he feels it's a bit more effective with foam. Could you get a better location? Yeah, off you go. Can you feel that? Yeah. And there's not a great pressure through the belt on your tummy, is there?
No.
It's just firm and it makes you feel safe.
Yeah.
Yep, that's what it's there for. Gets rid of any apprehension that you might get.
Brian, it's a bit redundant, but in watching your technique, you're knowledgeable of the facet plane orientation.
Yes.
And in order to maintain constant separation, constant traction on that segment, you keep your elbow in and behind your line of drive.
To keep it, yes.
So if the facet plane is cephalad,
Yep.
you're keeping your elbow
Yep.
underneath
Yep.
and in line with that facet plane.
Yep. Most important. Yes, if you don't, yes, you're quite right, because if there's any impaction of those surfaces, the patient will be in agony. It's got to be, as you say, straight up. And we should have said initially, I should have said, sorry, move slowly. Because if the patient really tries to move quickly, they can produce their pain, and the result is that you were unable to sustain that repositioning because they moved away from your hand too quickly. You just couldn't stay with the motion. Okay. So there we are, relocate, and he goes slowly. There's the counter pressure. Forward he goes. I keep that lift.
And you move with him.
And I move with him, yes. But let's be honest, you would do the same, I would do the same. Most people have unilateral pain. Mm-hmm. So I locate on the side of pain, and I locate on the transverse process rather than the spinous process. And that's easily done by bringing your hypothenar eminence to the appropriate level, locating on that level, and forward the patient goes. And as you said, look at my arm into my body.
And as you go through the technique, you're constantly changing your force, your line of drive,
yes,
and your direction,
yes,
to make sure you get in parallel with the facet plane.
Perfect. Yes, I did that very well. Right, again, let's say L3-4, locate, and look at my elbow now in my groin, because as he comes back, I've got to get that lift, and if I've got my elbow right here, I can use my pelvis to get the lift. So I'm going to separate your facets, and you're going to come back. Now, what stupid patients do, and I know you wouldn't be stupid, instead of extending their spine, they start leaning backwards. And suddenly you get a big guy like David here just lying on your hand, and of course you're in trouble. So I want you to extend the spine. There's your pain. Good. Stop. Yep. Now, this time, that's where you're going to do the bending. And you've got so used to protecting your spine, you're using your hips, but you're not today. There we go. There's locating on 3. Good, back you come. And you'll see I'm standing beside him. So in fact, he can come back and then return to the starting position. And I maintain that distraction. I can do it unilaterally. Let's use some foam for your comfort. There's the lift. Back you come. Oh, that's well done. And let go.
Now,
And as
Brian, as Ed goes through his motion, a lot of it is coming from his shoulders and his thoracic spine. If Ed had a lesion lower at 3-4,
Yes.
and your contact were lower, might the patient have to bring their navel forward to
And then
bring
come
about
back?
some lumbar extension?
Yes.
Okay.
Brilliant. Did you hear that? You're in the Navy. Take your navel forward. No, and that makes sure you straight away into that lower. Excellent point.
Okay.
That's what you're here for. Make sure I get it right. Good on you. But that's extension. Side flexion. He has pain when he side flexes. And you can imagine if you've got a jammed facet and you're side flexing to my side, you're jamming it more. So these people, again, locate, let's do it on the appropriate side. He has pain and restriction with right side flexion. There's the lift. Can you lean to your right, please? Thank you. And come up again. Goody. And that was sustained all the way through. And he went at a moderate speed and not rapidly.
And this is a perfect example, Brian, of what you described before about the facets possibly being jammed. This is the closing side.
That's right.
So if they're having pain on the right with side bend right, and you lift the joint and restore normal motion, you can then assume theoretically that you've taken a joint that was already closed, opened it to a more correct position, which now allowed it to move
Biomechanically as it's meant to. Yeah. And I see no conflict. And if you're getting an instant result, no one can fault you. Here we are, trying a technique that normally trying a movement that produces pain. You're using a hypothesis that's jam facet. We unjam it. They've got no pain.
And again, on day one, it's 3 repetitions.
Thank you. 3 repetitions on day 1, please. Rotation snags. Let's assume Mr. Ed has pain with left rotation. And the pain is on the left side. What I would do in his case is to separate the facets again at the appropriate level. And once I've separated them, he repeats the painful motion, and hopefully, well, not hopefully, if the treatment's indicated, he'll have no pain at all. Now, to do this, I'm not using a belt like I would with flexion and extension, because my arms are going to secure him and he'll feel safe. I put one arm around the patient, and that arm is going to give over pressure for the rotation component. My other hand is going to locate on the appropriate segment and look at my elbow into my groin. There's the lift. Can you feel that lift? Mm-hmm. Yeah. Now, you're going to go slowly to the left because I've got to go with you. Now, that's as far as you can go. And so I'll give you some overpressure with this hand and a little manipulation which would cost you $35.
Now, Brian, when you do this technique, there's a couple things that are happening that are less visible, and that comes from handling skills.
Yes.
The first thing, taking a step back, is knowledge.
Yeah.
The knowledge that you're not talking about thoracic rotation here. So as that patient turns, you're less concerned about this rotation.
Yeah.
You're feeling and palpating lumbar rotation, correct?
Yes, I am. Yep.
When you're palpating and feeling lumbar rotation, you're first applying a degree of traction as you do this with your snag, correct?
Yes.
And that's coming not from your arms, but that's coming from your hips
Yes, as I stand
and
up
your legs.
and my legs. Yes, thank you. As I extend my legs, there's that component. And round he goes. And I give over pressure.
Correct.
And end result, instant improvement in rotation and no pain.
And have you found in the lumbar spine, through your years of clinical experience, have you found that you automatically go towards a central technique, a unilateral technique? Do you favor one over the other, or do you, how do you take that approach?
Well, I favour the side of involvement. And before I do this, I normally have done a spring test on different segments of the spine, and I'm pushing on the transverse process of L3, L2, L1. And if I elicit a pain in one of those procedures, that tells me, try that level first.
Okay.
And sometimes, it's difficult to explain, but sometimes they've got pain with left rotation on the left side, but you have to go to the other side. A facet there is jamming, preventing natural rotation here, and that's sort of fermenting a pain on the other side.
So
Very rare.
You may have found over your clinical experience that you favor the involved side,
Yep.
but to stop thinking of the vertebral segment as anything less than one disc and two facet joints,
facets,
you would be doing the patient a disservice. So you have to be open-minded enough
yep.
to know that you may have to go to the other side. You may have to go up a level
Yes.
during the course of your treatments. This is where your handling skills become so important.
Yep.
Good.
Brilliant. Thank you. So we've done rotation, side flexion, and extension and sitting. Let's show some of these techniques in standing.
Beautiful.
All right. Standing and flexion. Mr. Ed, can you just bend forwards? Pain. Stop. Back he comes. We are now going to reposition one of your segments in your spine in such a way that when you bend forward, you feel absolutely nothing. Please move slowly because I'm standing up now and it's so easy to let your spine fall forward. I'll locate, let's say it's 3-4 again. I'm going to locate on the transverse process of 3 and look at my elbow again. It's in my groin. And here, I've got a belt to help him. And to help me, I'm going to place my hand on the bed. You probably can't see it, but if I've got something to place my hand on, it makes me stable and enables me to give you a good lift. Now, on the way forward, if you wish, you can place your hand on the bed so you feel safe. We'll try it without using the bed. Right. Wait on, let me lift first. Up, yep. There's the lift. Okay, now forward you go slowly. Yes, yes, yes. And up you come, I've got it, up you come. Absolutely perfect. Did you catch that?
Again, Brian, in your handling skills, what's so important is that you get behind your line of drive. So you not only drop your elbow down behind the line of drive, but you can also see as you get into the technique, your whole body is coming down. You're bending your knees so that you have some lift coming from your pelvis and from your legs, and that makes your hand able to stay softer, so you have a nice soft contact.
That's right. You used to give commentaries for events. You're so fluent. Just one more. Sorry, whoop. Be a good patient. There's the lift. He moves forward slowly. He stops. Yeah, and he used the bed because he felt safer.
Right.
And up you come, up you come, up you come. Well done. And you're in exactly the same position for extension. And make sure that the patient's extending, and as you said, push their tummy out and extend their lumbar spine. Because if the patient starts extending his hips and not his lumbar spine, you've got a great big fellow bearing down on you and doing horrible things.
Right.
So here we are. And it's quite nice that I'm smaller in stature than these two guys and lighter than this one, and because I have to cope with guys like this, and I can. It's easy. If you've got yourself positioned correctly.
We're using good mechanics.
Yes,
key.
yes. Now, here we go. Slowly come back, and notice I'm to the side of him so he can. Now that he's coming back, my elbow's locked in my groin, and it's working like a piece of timber. I don't have to do any lifting. He's doing the lifting of the facet by going backwards. Further he comes back, the more I lift.
And Brian, one of the things that makes this technique even more specific, and we can't show it here in our setup, but if you have the patient face the plinth with their hips against the table, so that as they extend back, they can't bring their hips into it at all. They just stabilize their pelvis.
I've never done that.
Bit, so.
Yes, of course they would.
Good.
Good on him. Just listen to what he has to say. Words. He's got some useful words coming out. Brilliant. We could, of course, do side flexion. Same procedure.
Right.
Same procedure.